from Bangalore. And I think with this, interact with other such systems being developed in the country and abroad. So in this session, we would like to highlight the needs for interoperable systems, discuss global learnings from our experts here, understand how some of the barriers to interoperability could be overcome, and also look at what the roadmap for interoperability could be. With this, I would request the chair, Shri Vishal Chauhan, to kindly give his opening remarks.
Thank you very much. Thank you very much, Kiran. Interoperable platforms is not a new thing. In many other sectors, we have seen this and we have seen very positive impact of it. You know, when I was in the power sector, the power exchanges were one of the few interoperable platforms where we see that earlier different players, different distribution companies used to call their own bids, and people were getting at different, rates, and a lot of problems were there. Now we made a power exchange. Power exchange was made with the PTC Finance and all these organizations. And it has made life so simple, and the biggest beneficiary has been the consumer, in the sense that now the average power tariff is about 3.5 rupees, which were earlier used to be 6 rupees, 8 rupees, there was no. Similarly, in commerce, a lot of platforms have been made, and I must congratulate NHA. Now in the health sector also, they are working towards this unified health interface and all these things. They are very, very useful. They have proved to be ultimate. The patients, the citizens are going to be the ultimate beneficiaries if we provide a solution like this. And I'm very happy that today such a big event has been organized. There is so much of enthusiasm among the participations, from the participants, from the government sector, from the private sector, because we are the biggest beneficiary in the health ministry of this whole exercise. We are the biggest consumer of all the public goods are created by the NHA. In the sense that in the ministry we are running about 45 portals. In the NHM only we are running about 15 portals, and unfortunately these portals do not talk to each other. So what we have we have a portal for TB, we have a portal for RCH, we have a portal for reproductive child health, we have a portal for NCD, and these portals work in silos. They do not talk to each other. And what happens is that if I always often this example, if there is a woman, she is registered in a RCH portal and she is having a TB also. So TB portal, Niksha portal does not know that lady is pregnant. It doesn't capture that kind of a data. And RCH portal does not know that lady has a TB also. So we don't know it's a high risk pregnancy, more efforts are required. So with this kind of a arrangement, when we have an interoperable kind of a platforms are there, then you get a full information about various patients, what has been the past history, what has been the, so we are able to connect labs, we are able to connect health facilities, we are able to connect citizens, and it leads to the empowerment of the citizens, in the sense that at the touch of a button he gets his entire information. So with this opening remarks, I will request Kiran to please go ahead. Let us take this discussion forward, and I am very, very hopeful that it will be very, very useful for all of us who are sitting here by learning from each other. Thank you.
Thank you, sir. So we have Dr. Pramod Verma with us, who's been the chief architect of Aadhaar, and we have seen what Aadhaar has been able to accomplish. And he's also been working very closely with the National Health Authority in building the unified health interface. So welcome, Dr. Verma. And I would like to start off with you, in fact, with the very basic fundamentals, where if you could please throw some light on what are the No, are you muted? No, he's not muted. If any other speaker is able to speak, I mean, in fact, we also have Heather Grain with us, who's been a health informatics and educator, and who also has done a lot of work on standards like SNOMED CT and HL7. Maybe we should try to we could also try to talk to her and also check whether it is working only for, not working only for Dr. Verma or for everybody else. No, we can't hear you either. So it is, I think, our own problem. Huh? Who is the IT person here? Okay. Okay. I'm sorry for that. Small little issues. So since you can hear us, I think we will actually take some questions from our physical, those with physically here. I'd like to pose my question to Professor Disanaike. You are heading the Commonwealth Center for Digital Health. Could you please throw some light on what kind of work is being done there and where interoperability comes in here? And why do you think it is important for cross-border connectivity? Please.
First of all, thank you very much for inviting me to this meeting, and it's a pleasure to be here. Just to give a little bit of an idea of the Commonwealth Center for Digital Health, the Commonwealth as a a group of nations that spread across the world. The health ministers meet every year, and around the year 2016, the health minister adopted a policy brief, which was a policy for healthy health systems. To complement that, in 2017, the Commonwealth also adopted another policy, which was on digital systems for One Health. And to enable that to be implemented, the health professionals led by the Commonwealth Medical Association came together and formed a Commonwealth Digital Health Initiative during the time that I was the president of the Commonwealth Medical Association, and formed a Commonwealth Center for Digital Health in the year 2018. Amongst the things that we do is advocacy with Commonwealth health ministers to take forward the agenda of digital health. And one very important element of that is enabling health systems across the Commonwealth to interact and talk with each other. At policy level, it happens with the Commonwealth health ministers meeting with each other. But as you know, when we look at the health systems across the world, and if you look at the health system of India, India is actually providing high-end healthcare for citizens of Commonwealth countries. There are a lot of citizens of Commonwealth countries who travel to India to obtain high-end healthcare. And in that kind of background, what should the digital health systems look like? How can it provide interoperability? How can it provide for patients who come here, obtain healthcare, and go back to their countries and are followed up by their healthcare providers? That's the kind of discussion I think we need to engage in this forum, and it will also be relevant to India. So I think there is an international minimum data set that has been proposed for patients who engage in that kind of, if you want to call it health tourism, medical tourism. So I think going forward for India, we need to look at capturing that kind of concepts so that cross-border healthcare can be enabled and operationalized. Now, to do that, I think we need to look at regulation, so at a very high level, and even in the proposed the shared healthcare hub that India has proposed at the WHO, working with the WHO's digital team and so on. We need to look at how we can enable international regulations to capture that kind of healthcare seeking. Then, of course, we also need to look at capacity development in the healthcare domain that would enable that. And that would mean also development of capacity within the healthcare sector in different ways. So, for example, as another role that I play is as the chairman of the president of the Sri Lanka Medical Council, which regulates healthcare professionals in our country. I'm sure, so the regulator has to come in to make sure that those who are providing healthcare are actually properly certified and regulated, and that information is shared with the healthcare system. So that's another aspect that we need to look at, the properly certified, registered healthcare providers are providing. How can we share that information across the board so that when healthcare is sought across the border, how do we really make sure that proper registered healthcare providers are providing healthcare, and so on. So this kind of high-level discussion has to happen while we also look at the technology enabling interoperability. So those are the things that I'd like to kind of put on the table, as it were, for discussion. Thank you.
Thank you, Professor Desanayake. I think we seem to have solved our connectivity issue. So back to you, Dr. Verma, with the initial question that we posed to you.
So I presume I heard part of the question. I presume the question was related to what is the need to define interoperability.
Yeah, I mean, basically about what are the fundamental design elements that are key to ensuring interoperability, and and to make sure that they could actually be able to work on scale. So please go ahead.
Yeah, so I think we look at interoperability. There are so many parts to interoperability. I think fundamentally, interoperability, while necessary, it takes effort. It takes effort by the entire ecosystem to sort of align and come together and agree. So it is almost always being painful, and we saw that in the vaccination credentialing, right? You had someone, India would have has to go getting the credentials out. Australia has to go, and the US has to go, paper-based and so on. So, and globally, interoperability was difficult to pull it off, for various reasons. So, while all of us fundamentally believe in the necessity of interoperability, otherwise the silos systems are absolutely unacceptable. It takes effort to bring someone as a facilitator. The facilitator must bring the ecosystem together, inspire the ecosystem together, provide value so that they actually agree to align with interoperability. So that is the governance of the interoperability aspect. From a tech perspective, you should look at sort of 3 layers of interoperability, right? Look at from an architecture perspective. One, identity and credentialing interoperability. That's where the trust becomes fluid. It's very, very important. Trust moves from one system to other system, for example. And you have been doing, health facility registries and credentialing, health professionals, doctors, allied workers, nurses, and so on. Each of those identity and credentialing needs to be interoperable and portable across multiple systems. Otherwise, I would be in a national doctor registry, but if it is a portal and not an open API-based system that allows me to move and establish the same level of trust in my private hospital system or any other system I'm interacting with, the value is. So the first one is ID and credential. Absolute essential for trust, fluidity of trust. The second layer is transaction interoperability. So once the identity and credentialing is interoperable, I can say who I am, what I do. If I can prove that systematically, properly, I should be able to participate in a way. If I'm a consumer, I should be able to get access to healthcare, affordability of care, insurance, claims across how does interoperability of claims work? Otherwise, we are being extremely broken claims processing, which is inefficient for everyone. I mean, for consumers, the hospitals too, including insurance companies. So I know that you are on building the CX and so on, the healthcare thing. It's just the transaction interoperability is where two participants, completely two different systems, come together to say, I can offer something and I want a need and it will connect real time. That is where open APIs and so on are defined. So that interoperability is about API design, protocol design, and we have been talking about that a lot of that. And the third level, once identity is transaction connectivity is interoperable. Third level is the data package. Data interoperability. That's where the bias analytics norm has been formed, right? We have done this. Thankfully, I think the international community has been, the health community has been working on much of the standards in the data layer, which we should elevate. Data interoperability allows once the transaction is connected, once the data packet moves from one system to other system, for example, my healthcare record, move from one hospital to other hospital, how does the next care provider interpret that data, analyze that data, process that data without you being the paper? And then you can digitize that data interoperability and transaction interoperability. You can actually bring dramatic efficiency and dramatic reduction of cost, which is what a lot of us care about. I think one is efficiency, but unless the cost is dramatically reduced, access to healthcare becomes preventive and very difficult for people to track because it gets very hard. So very cost, that turns into costly affair. So I think our work on data portability, USI, like transaction portability, and of course ID, credentials, and HSP, where they top 10, credentials portability. Actually, I was taking off very light. But when you design interoperability, put off an interoperable design in 2 months or how that long takes and so on. Systems can be lost, but the interfaces take effort. And because we are collectively agreeing as an ecosystem what that open interface and interoperability is like that needs future proofing, but evolvable and generalized.
She, who is the CEO of ONDC, where excellent work is being done in bringing about this kind of interoperable structures in the commerce side. So would you please explain us the work that you are doing and also how you think cross-sector interoperability, that is, while we are, this Arogya Manthan is about health, how do you think commerce and health and how interoperability between these sectors would be important?
Thank you. So what I'll do is I'll briefly, probably a couple of minutes, tell you what we're trying to do in the commerce side and probably take some learning in the way that we are doing. And more importantly, the institutional arrangement that we are building up, which could help in creating such an ecosystem which is interoperable and thriving. So as we all understand that the, while in this, Internet started www, which is powered by HTTP, made an open protocol by Tim Lee, actually made Internet what it is today. If imagine he had created a private network, probably we would have had ATTP and BTTP and probably we would have been paying $50 each to access. But he took a very fundamental, and he would have been multi-trillionaire, but he took a fundamental contribution and says, let me create the underlying protocol open and let the internet get built on the top of it. So first build was all about information dissemination. In that information dissemination, it's completely open. I can create, so long as I can create an HTML page with HTTP protocol, I don't have to worry, should I put in Chrome, should I put in Edge, should I put in there, because Chrome has got large volumes and nothing is of matter to me. I can make a page and make it available in the internet for anybody to discover. It means discoverability comes from the commonality of the open protocol. What it will also mean that it puts the power on these individual agencies that their, their liver is what they have to offer, not whether they have a captive user base. If I create a portal, koshi.com, and we have one in NHA.com, both have equal discoverability. But if when NHA is more relevant for a larger cross-section of people, then more people will go. Traffic is determined based on the what is being at offer. Unfortunately, by the time transaction came, it ceased to be the case. It became proprietary network. The proprietary network has multiple challenges that we have seen. It breeds concentration. It also leads to some not so good practices. These are the challenges that is faced. And innovation is limited to few set of people who have the power or influence or the deep pockets to handle completely end-to-end one. When it is really interoperable, as Pramod explained, we are creating the specifications of Lego blocks. So, some people may develop new blocks, but so long as they keep the standards proper, the blocks can merge into the larger story. Some people may bring together multiple blocks to create a new service. Some people may make a spacecraft, or somebody may make a bullock cart. So again, innovation thrives, not in very limited pockets. And that's a challenge that we have in commerce, that's a challenge we have in health. And when we create these interoperable standards, you would see innovation thriving from multiple corners which are large and small, adding to the total space and making meaningful contribution and still being sustainable without being eaten up anything. So what we are doing, from an institutional side, we are all coming from the health side. So what I'll do from an institutional side, what we are trying to do, which might be a probably interesting thing. We believe that we have 3 roles to play. While in a very, very basic thing, it's only protocol, like Pramod and team has already helped us to shape the thing, up there, and somebody can take it and work on it. You don't need anybody to do anything. That well explained. But to create a healthy network, you need some amount of hand-holding support. So we have 3 roles to play. First role is that we have a developmental role. That developmental role has 2 components. One is, of course, the getting the digital rail up and running. Use the open source protocol that we are using, build on it whatever layer related to, let's say, the network layer related to commerce, which will, in the same way, you will have network related to health. So that is the getting the rails up and running. Second thing is, this will provide opportunity for everybody, big and small. But the small has a disadvantage. Big can take it and work on it. So you will need to have some hand-holding support to the smaller players, probably in terms of SDKs, probably in terms of capacity building, probably in terms of tools, etc., so that they can take advantages as opportunity that is shaping up fast. Because otherwise they don't have the wherewithal. So we have the role of that, the development role, as I said, creating the digital rail and be an enabler to people who are not so well endowed to take advantage of this opportunity. Second role that we play, we try to play, is the role of a network orchestrator or a manager. Because it's not a flea market where anybody can come and do anything what they want. So when there are different entities coming together, we have to have very strict agreement on how they will all collectively interact with each other. Okay, in terms of the complete business transaction, whether it is in health or whether it's commerce, same issue comes. It's not just about data exchange, it's also about how they conduct among each other. So, and those things has to evolve continuously. And it has to evolve in a consensual fashion. So we play the role of that and make sure that as much as possible it is programmable, protocolized, so that tracking, monitoring, enforcement become a possibility. The third role that we try to play is that of a service provider. Wherever we can do common services, which are relevant to the community at a large, which can be built without conflicting with anybody, and not to usurp anybody's contribution, but be an enabler. Like what you're doing, the registry, of course, is a common infrastructure. A gateway is a common infrastructure. Consent mechanism that you have. Similar kind of, so wherever that, or even a rating across the network. Because today, otherwise, if you are a part of one network, you have a rating, when you get out, you're out. You run up. So these kind of commons thing, Okay. And actively, if this entity look at, without trying to own everything and hold everything and becoming, monolith in itself, but enabler and also encourage, create the standards to even build those common facilities also being done by multiple entities, still be interoperable. So that's a kind of role that we are playing in institution. I mean, this is what I just want to put as, share information sharing from a different sector. And as you, and the last point I want to just highlight, Kiran, is the very important point that you said. There, while these are two different sectors, there is still interoperability, meaningful, so that we don't end up duplicating. If you look at commerce is common in health as well as in the regular commerce. Whether it is in pharma or whether it is services. Some cases you have very, very specific, very strict specification which are health related. Some of them are not, some of them can be worked within the larger framework of the commerce itself. I mean, I'm just taking one example. Let's say whether it is OTC drug. But there's no prescription issues that is coming. I mean, similarly, there could be many areas where we should find a ways of avoiding duplication at the same time working to ensure that these can, easily integrate and interface. And that's the kind of thought I want to, put it as a first session, and I leave it to the rest of the, the colleagues to come up with their thoughts, and then we can take it forward.
Thank you, Mr. Kaushik. Now, I think we could now go to one of our speakers who's joined us online, Dr. N.T. Chang. Here, as Chief Medical Informatics Officer and Head of Information Technology, Hong Kong Hospital Authority, could you please throw some light on how Hong Kong Hospital Authority is addressing this issue of interoperability, and what kind of work you have done, and what is it that we can learn, or what are the cautions that you want to put across to begin with? Dr. Chang.
Okay, thank you. Kieran, just wanted to check first of all that you can hear what I'm saying?
Yes, we can.
Oh, excellent, excellent. So I would love to have been there in person. I'm afraid that I'm unable to travel, so the miracles of interoperability video conferencing, so we can now talk to each other, so that's great. But, okay, so let me just share with you a little bit, as you say, of what we've done in Hong Kong. I basically spent my whole informatics career here, so I can tell you what we've done. Hopefully it might provide some learnings for everybody here. One of the first things I think we're talking about is that we built our own healthcare clinical systems in Hong Kong since the 90s, and we've done it both at the institutional level. So I'm from the Hospital Authority, which is a very large healthcare network. So all of the public hospitals in Hong Kong are under one single organization. And what I do is build all the systems for all of the clinical care in those hospitals. Now, we built upon that work subsequently, and we also built out systems which allow the rest of the healthcare ecosystem, which means we have a number of private hospitals, a lot of private practitioners, other sectors of healthcare, pharmacies, laboratories, and all those people as well, to also share data in an interoperable way. So this is sort of where I come from, having built a number of systems that offer that. So I think the first thing to understand is that when we started this whole journey, we were basically a fully paper system back in the 90s. And when we started embarking on this sort of digital journey, this digital health journey, I saw that the most important thing that we were doing in the digitization of health was getting a shared electronic record, a patient's single electronic record, which would document what happened to that patient, what are his diagnoses, what are his results, and all that stuff, what's in another patient. And so, because healthcare itself operates, unfortunately, as a whole bunch of silos. Each specialty is focusing on, their part of the body. Each hospital is looking after their, admissions, and each clinic is looking after their sessions, right? And a healthcare record for that patient, which is common. Okay, so part of that was, I had the advantage of being able to build a system which we could deploy across a very large footprint. Now, even having the same system across different hospitals doesn't guarantee interoperability. Because you can buy any system off the shelf today, implement it in your hospital, and it doesn't speak to the next hospital using the same system because they haven't done interoperability at the very core of it. So that's key. It's not just the system itself; it's also how you implement, configure, and deploy it. So we did both. We said the systems must be built in a way which, and I love Dr. Farmer's use of the word generalizable and all those things because those are very key. It has to be able to handle all the things that the patient is going to encounter in their healthcare journey. And there's clinical medicine is, as all of you know, tremendously complicated world. With biology, with pathology, with psychology, and with organization, which is to do with healthcare providers themselves. So it's just a tremendously complex world, and the information is correspondingly complex. So to be able to build a system which you can scale and generalize, now that's difficult. And to have that information also then flow across the system is also, it's tremendously difficult already, and it's impossible if you don't do it from the outside. So the key, I always say, is that to understand that this is actually fundamental. Everything you do, it must be built with interoperability in mind from the outset. This is very hard to re-engineer in the back end. Yeah, absolutely. So when we did this, I was thinking mostly about the actual care delivery. So when a patient, I'm seeing one specialist today, and then a few months later I come back to see another specialist or come back for a follow-up. The information is all there, right? And it's in a way which is very easily discoverable. So it doesn't matter what the data was that the first specialist entered. It's there in a way which is easily found by the second specialist, and then by the health people, the pharmacists, and all that. They can all see the same information in the same very easily discoverable way. And the understanding of that, the other thing I have to emphasize is that as information flows through its system, in healthcare, because it's such a complicated information set, it's very easy for that meaning of that data to shift if you don't do it properly. And any shift in meaning between one system and another, particularly things like translations and mappings, that could be disastrous. So this is something that we have to be very aware of. You have to really preserve the meaning of the data itself, which makes it harder than just technical interoperability. You have to do semantic level interoperability. And again, difficult, impossible if you don't do it right. Okay? So we were doing this. We were building systems in that more generalizable way. We were building the standards upon which the information was being captured, and we were deploying those standards as much as possible at the same level of granularity, the same meaning across the board. Now, to be honest, this didn't all happen a while ago. I mean, because of the limits of technology back in the old days and the varying rates of adoption and everything, we had pockets of non-generalizability, and we had to try to bring that back in. But they have the same sort of underlying development to make that much easier. So the healthcare bit is, okay, so that's fine. We're able to share the record between our own providers in the hospital authority first, and then out to the rest of the community using those same sort of principles. But then, to be honest, the real payback for all this work is not just in the healthcare itself. It's in what the data can do for you afterwards. Because, to be honest, we're talking about digital health is, it allows a person to get good quality care everywhere, but it also allows the care itself to be much improved. It allows the whole healthcare system to be more efficient, sustainable, and it allows you to build new models of care which were impossible in the old days of pen and paper, right? And so this to me is the real value of digitalization of care, is that it can be tremendously, the word disruption is what you might use in the tech world. Normally in healthcare, that's a bad thing. But in this case, we're talking about dramatically improving things, enabling, quantum leaps in quality, and being able to have much more rational planning of services, nowadays a lot is about patients themselves. How do they get engaged in their own care? How do you present the same information to them that was captured for clinical purpose and now present it to a patient so they can, manage themselves better? And again, if you have the data collected in an interoperable way, a standardized way, you can then, since you know what it actually means, you can reformat, you can whatever you need to do to make it more meaningful to the patient. And to be honest, this sort of the level of information you need for healthcare it's different between a specialist and a GP, for instance. It's different between what a nurse might need to see and a pharmacist might need to see, and it's definitely very different for the patient. And having understanding again that so that you can manipulate the information, that's probably the wrong word. You can adjust the information presentation to the level of complexity and granularity that's needed for that particular purpose. And once again, it's difficult but impossible if you don't have that concept up front. Okay, so I would just close with the example that we've all been given, which is COVID, and the ability to have data which is flowing from all parts of the community where things like vaccination and tests and people are getting sick and all of that, and having that collated together in one central database. Well, that's how we do it. We actually report it all together in one central database, and knowing that we were counting the same thing and all that sort of stuff, maybe at least we knew COVID itself. Okay, tremendously difficult, of course, but at least we knew where we were because we busted the whole thing, and so then you can make policy decisions about healthcare and immigration and lockdown, all those sorts of things. You can make those on a very informed and real-time basis. And again, at the core of it, because we have data flowing through the system, interoperability, semantically interoperable, we're able to achieve some of that. So I just think it's actually core to the whole concept of digitization of health. If you don't do it with interoperability and semantic interoperability in mind, you're not going to be able to achieve many of those good things that we need to do to make healthcare sustainable in the long run. Thank you.
Thank you, Dr. Chang. We've heard Dr. Verma, we've heard Professor Dissanayake and Mr. Koshi and Dr. Chang. But at the end of the day, policy drives systems. And our chair is actually Joint Secretary Policy at the Ministry of Health and Family Welfare. So, sir, having heard the speakers, we would like to understand from you what kind of policy roadblocks you think we currently have, or how do we facilitate this kind of interoperability among systems through policy means, and what kind of policy work you think is required by India to be able to achieve this kind of work that we are proposing to do.
Thank you, Kiran. When 5 years back or 6 years back, we made so many portals and started working towards digitization of the health, we end up collecting lot of data, lot of information which is actually required or not required. And COVID has been, as driven by R.S. Sharma sir, it has been such an eye-opener for us, which told us that the minimal is the better. And now what we have been seeing is that now we have a NCD portal where we take care of the non-communicable diseases like hypertension, diabetes, and the 3 common type of cancer. In that we are collecting whether, I know there are social determinants of health and we need to have data like whether there is a safe drinking water in the house or whether there is a toilet in the house, but we have made our system so heavy that collection of retrieval of the record, it takes 5 minutes for a field level officers where the the internet connectivity is an issue and training is an issue. So what COVID has taught us is, if we have collect only 4 or 5 fields, then the system runs so perfect and we don't need it. When I approach a doctor for hypertension or diabetes, he doesn't ask me all these questions. Of course, family history is important. As I said, social determinants of health is important. But all the time, this kind of in Niksha portal, in the TV portal, we had 47 fields. To do the entry for one patient, it requires half a day for the field functionaries. So what we are doing is that now recently a simple app under the Indian Hypertension Control Initiative got a UN award 3-4 days back. The simple app is so simple, it just has a past data of the patient, whether what has been his hypertension readings, his name, his age, all these things. So what we are now doing at a policy level is that we are unlearning so many things, and we are going back to the basics. And Niksha app we have simplified, NCD app we are simplifying from 25 fields. We are filling CBAC forms where 25 fields are there. We'll continue to do that. But for a medical officer, it is important that he use the portal while seeing a patient. We do not want that he sees a patient and then after 3 days somebody is doing a data entry. So objective is that while seeing the patient, we should be able to do it. So this is a big challenge for us, that how do we simplify our so many portals, how these portals talk to each other. These are very, very useful portals, but we have to make it so user friendly. We have 2-3 portals. We have for the hospital management information system, one made by CDAC, one made by the NIC. Unfortunately, what happens is that while designing these portals, we end up putting so many fields, we make it so much user unfriendly that hospital staff find it very difficult to use that portal. So that is a big learning after the COVID, is that we have to make our portals very simple, which are useful, where the speed of connectivity is there. So that is one thing. Second thing is that as we go for the interoperability, it will helpful for us in the continuum of care. If a patient is referred to from a sub-center to a district hospital, then we have a ABHA ID, and that is the best linkages. If a ABHA ID or a QR scanning is done at the district hospital, we come to know that yes, patient was referred and he has actually reached there. After seeing the patient, a specialist say you take this hypertension medicine and every month you collect your medicine from the primary health sub-center. Now, if the patient goes back, collect his medicine on a monthly basis from the sub-center, then we come to know, yes, he is collecting the medicine. If he is not collecting the medicine, that it means if he has not reached the facility and his ABHA ID is not, QR code is not scanned, then we come to know that patient has actually not come to the facility. So the continuum of care is very, very important. A very good part is that data is wherever the data is there, we are not keeping data at one place. So in a primary health center, there may be a private lab which is doing the testing, so they can use this ABHA ID. So the lab data can be with the lab. But it is through the M2 and M3 level integration, it is made available to the doctors, to the patients, and patient is like, patient is feel empowered that he can see. Also one more thing at the policy level is happening is that the data was available to the national level user, the data was available to the state level user, and sometimes to the district level user, but we never made the data available to the patient. We thought patient doesn't need this data, only we should know this data. So patient should also know what was his history of the hypertension, what was his history of the background. So one more thing is that it's like now in the COVID app, one can see when he was vaccinated. Similarly, recently we made a portal with the help of the NIC, on the blood donation. A patient can see his own history, when was the last he donated, when next he can donate. So similarly, patient should be empowered enough to know, or citizen should be empowered enough to know that what has been his background, where he has gone, what he has gone. So now making data accessible to the citizens also is also one policy decision that we are taking now. So all these things, I hope that it will be very, very useful. Thank you.
Thank you, sir. Policies are made and then they need to be implemented, and NIC has been the government's IT service provider since the very beginning. And the NIC's work in developing portals earlier and even today has been very, very crucial. And we have the Director General NIC with us. We have e-hospital solution prepared by NIC. So could you please talk about how you are thinking about taking this to the next level and making the e-hospital software a more interoperable, easy to use software that can actually that can actually talk to more and more systems.
Thank you. Good afternoon, everyone. See, I would answer this question, but in 2015, CUNHA was our IT secretary. And we started all these concepts in the Digital India when it was launched. So he guided us to make a appointment system where a patient can take an appointment in any of the government, central government or state government hospitals. And it was fairly easy, as Dr. Pramod just mentioned, that identity of the person has to be established. That's the first registry, so that the hospital can understand who has taken appointment and the patient can understand who has taken appointment. And similarly, at that time, R.S. Sharma sir guided us to make universal HID in all the e-hospitals. E-hospitals is working in almost 1,000 hospitals of the government and the state government, central government and the state government. And concepts were same, that a patient who has taken treatment in one hospital, when he goes to, or he's referred to another hospital, all his records get accessible. I just want to put 2-3 points on the table. Most of us may not have visited banks for last many years. It is not as if the banks have got digitized now. Banks were having core banking for many, many years, maybe 15 to 20 years. And each one of them had their own solution. So you have to have the bank's app, you have to have his own portal, their own login, their own way of authentication, and then you could do all the transactions on the bank. But what has happened in last 4 or 5 years is UPI. But what it has done is it has used the same digitization which has been happening in banks for years. And it just put a layer above the core banking. One can transfer a small amount of money. It could be as small as you go to a grocer's shop and spend few hundred. You don't go to the net banking now. Okay? So all you do is they built it, what we call as the topic of this session is interoperability of banks. So money goes from one bank to another bank without either me logging into the net banking or a core banking or the other person logging into the net banking or the core banking. So they built a layer on top of that and simply resolved from which bank account the money has to go to which bank account. And then hundreds of applications have come over it, whether it is Paytm or even any other application. There are hundreds of applications. You use this layer and you transfer money, and maybe people are not even keeping money in the wallet now. So your mobile has become your wallet. Same has happened so in the financial sector it has really happened. Interoperability has really happened to a very large extent. Two things I was driving out of it. One is the backend needs to be digitized anyway. So if the backend is not digitized, you can't build any layer on top of it. And second is the backends have to talk to each other. That's the simplified way, as Dr. Pramod Verma mentioned. And Aadhaar, when it came, that was a game changer. So when we started Digital India under leadership of Dr. R.S. Sharma ji, Aadhaar had just come, and we in the government in NIC set up Aadhaar authentication big way Aadhaar authentication gateway and linked all our applications with the Aadhaar. And based on that only, we could link other applications. Other example I would like to give is the way we book our hotels, airlines, make my trip or any other thing. It is not as if earlier I was not able to book a hotel. Okay. I can go to the site and do all that and I can book a hotel. But I have to go to 100 sites. And I won't even be able to discover a site. I won't know what is the site addresses, etc. Or airlines. So I remember when earlier we used to book the ticket, we used to always go to Baman Lorry and sit on his PC, and he was able to show us all tickets which are available, which is cheaper, which is not cheaper, what is the connection, etc. Which means that airlines were having backends even at that time. I'm talking about 20 years back. So all the airlines had a backend, which was a very strong backend, but it was only with them. So only with companies like Baman Lorry, who had a connection with multiple airlines, that facility was given to only them. But now with this interoperability, that got opened up to every mobile. Sitting here, I can see now every train ticket, every airlines ticket, every hotel ticket, and anywhere in the world. So we don't have to get into that. Now let's extend this analogy to health. I am still doing all the diagnostics in a digital way. When we do our COVID test or when we do our other lab test, Path Lab and all other agencies, everybody is doing digital way, including AIMS and all other state government hospitals and all. Nobody is writing on the register now. Okay. So all the reports are available in their backend. And when I go to an hospital, whether it's an AIMS hospital or I go to any state government hospital or I go to a private hospital, each one is having an HMIS. I don't think nobody is registering the patient like we used to at that time. Even when you go to a small eye clinic or any hospital. So registration is there, your old history is there, you go to the doctor's chamber, he can see when did you come last and what did he prescribe at that time and what treatment, what is diagnosis or whatever is test, etc. But they are all confined to within that institution. So within that hospital. So backends are fully ready. And that laborious work has been done. I'm sure NIC has done a lot of contribution in that, because what JS was just mentioning, I remember in 2009-10 time frame, when the health ministry, they call it RCH now, but at that time it was called MCTS. So where each and every, we used to call it, now we call it wellness center, but at that time it was called sub-center and CHCs. And there were about 1.5 lakh, 2 lakh sub-centers. So each and every record of immunization given to children or treatments given to the pregnant women have been digitized, and it's available in a digital format. Similarly, CGHS, I'm not sure how many of you may be availing CGHS facilities, but for 15 years, Ministry of Health has been working together with NIC and MAITI to make whole CGHS digital. So you know when did you visit last, which doctor you visited, appointment of the CGHS, etc. Similarly, today in the beginning session, inaugural session, Minister Sahab has mentioned about ASHA, ANM ASHA. So ANM was at the sub-center, what the Minister Sahab mentioned, and ASHA was at down the sub-center, which was in the population of 500 people or 1,000 people, one ASHA is there. So Ministry of Health has, I agree that the technology at that time was little older, and thinking at that time was but we had to collect a lot of data. So all these things were there. But now the time is there when ABDM has been set up, about 1 year back, and they have set up the gateway, I may call something equivalent to a UPI gateway, an intermediary gateway where all these initiatives of the central government, state government, private hospitals, insurance companies, they all can talk to each other. And as Dr. Pramod mentioned, so primarily the primary is ABHA ID. Okay? So the trust has to be there, a person has to be unique. If one patient goes from one place to another place, so currently CGHS has its own ID, RCH has its own ID, and many other e-hospital has its own ID. So there is not a unique ID which can identify a person uniquely across all the systems. So that's an ABHA ID. And then ABDM has also set up health facility registry, just like the bank, you have this IFSC code and etc. So just by looking at the IFSC code, you can identify which bank and which branch. So it's a unique all across the system. That's how they can talk to each other. Otherwise, they would never have been able to talk to each other. Health professional registry, like doctors. So doctor ID has to be unique. Then only one can be able to refer and exchange the data, consent management, etc. So now for last 1 year, they have built up these big value gateways. And for us in NIC, since we had the digital platforms for the back-end data, I agree that we had a unique ID of our own, like many other systems. Like PathLab will have a unique ID of its own, somebody else will have a unique ID of its own, Apollo will have a unique ID. But now when ABHA systems gives us an ABHA ID or an ABHA address, it is easy for us to, instead of using our own ID, we can use our own ID within our internal system. But when we exchange the data with somebody else, we can exchange the data with the ABHA ID. Therefore, all our 4 or 5 big applications, which are online appointment system, e-hospital system running in 1,000 hospitals, RCH, which is running in 1,50,000 health wellness centers, ASHA system, and some more CGHS system. All of them, we are working together with NHA in a very dedicated and mission mode way, and it's easy for us to implement. And since it is easy for us to implement, I'm sure it will be easy for all the other hospitals who are not using NIC system, who are using their own systems. Since they have made the protocols, they have made the standardization, they have made the registries which are common across everybody, so it will be very, very easy. It may take a few months. But end of the day, the mission is, today when I go to the hospital, we used to call, our secretary used to call at that time, we are carrying our jhola along with us. The jhola has all the lab reports, all my previous history, all tests done so far during the last maybe 1 year or so. And when you reach the doctor, I don't know how much, he keeps asking you to show reports, and then you take it out from your bag and start showing that. So we, as JS Saab has just mentioned, we have to make a system very simple, that when I have to get rid of this whole bag of reports which I will go and visit a doctor. Just like my mobile has become my wallet now, I don't carry so much cash. We go to any shop, you can buy anything which you like, just by your scanning your UPI or something like that. So similarly, when you go to any doctor, it should be so easy, and I'm sure with NHA taking the lead in this, and everybody, all the ecosystem, and you are all from the industries and from the government also, when all of you will join together and make a system where one can go and show my health records, previous health records to any doctor. May not be of the same hospital. I can go to any other hospital and show him my lab reports, my health records, etc. And I'm sure under the leadership of CEO NHA, he has built CoWIN, he has built Aadhaar, he has taught us a lot, and we are still working together with him. And I'm sure with this vision can also be realized very soon. Thank you.
Thank you, sir. So the message that we seem to be taking away from what the DG NIC had mentioned is the back-end automation has happened. At the back-end, everything is available. But now, how do you actually move data from point A to point B? And also, while we talk about the back-end automation, what kind of standardization has happened so that this interoperability can really happen and the data can move from A to B? Because there are layers, as we say in interoperability, of transport interoperability or structure interoperability or the semantic interoperability that has been raised. So we have Heather Grain with us, who's worked on standards such as SNOMED CT and HL7. We'd like to hear from her as to how these standards are useful and need to be adopted by all the systems so that this interoperability becomes ingrained into the entire system. Over to you, Heather.
I would love to speak on that, but I would also love to say how much I've enjoyed the previous speakers and how much I agree with probably 95% of everything you said. And some of it I've been going, yes, I agree, fabulous. So I would like to look at the perspective from the standards viewpoint. Having congratulate the NHA on the wonderful start you've made, what is a really, in some ways, treacherous paradigm shift that we're undergoing. But the biggest part of the problem that I'm familiar with is the illusion if you think that things like 8275 and SNOMED are enough. They are part of the solution, absolutely, but they are not the end. And I often use it as a simple analogy where I say standardizing the data at the point of the message is too late. It's like putting your running shoes on halfway through a 100-meter dash. That's not a good way to come first in the race. It's a very bad way to come first in the race. That doesn't mean that we don't need H7. It certainly doesn't mean we don't need SNOMED. We need them both, but they're part of the solution. So I like to go back to a simple ISO standard called ISO 13606 about electronic health records and their structure. It recognised that one of the reasons that finance, you can get a software package from one software vendor and you can transfer your data to another one fairly easily, can't you? Because they share a common infrastructure. They all talk the same way all around the world. We talk about income, direct expenses, general expenses. The chart of account is common. The terms we use are common. Interest, we all know what that is. It's the same all over the world. The interest rate may vary, but the principle of interest and the different ways it can be calculated are well known and agreed and have been standardized for nearly 400 years. So when IT develop systems in that environment, they don't consider redeveloping those ideas. They use what's already there. So healthcare, about 15 years ago, recognized it needed a standard structure that was similar for its electronic health records. This isn't talking messaging. It's talking the health record and its data. It recognized you need a standard structure for visits, or what we call compositions. Things that are signed by, a particular event happening. Then you need observations, the results of tests, things, what is a person's blood pressure, all those sorts of things are all factual observations. Then you need instructions. I want somebody to do something. Then you need actions. I've just given the patient this drug. I've just done this operation. Then you need evaluations, which are things that the clinical professionals might do to assess those observations and the actions that have been taken and say this is the diagnosis. You also need the identity, demographics and fiscal components, but we need them structured in a way that we all agree on. And that's where life gets difficult, usually in healthcare. But there is an international standard called OpenEHR that has hundreds of thousands of the data elements used in clinical care already with data items defined. They use Snowden to define those data items. They use Snowden to define the value domain of those data items. So they provide an agreed structure and an agreed data specification for what they call a maximum information model. So it's not just what you need for reporting, it's everything a doctor might need. So if we think about blood pressure, a lot of doctors will just want two values, diastolic and systolic pressure. That's it. But a cardiologist might want to know whether this was taken after exercise, whether it was taken, if it's a child, was it taken with a pediatric cup on their arm, or an adult cup? Different levels of data are needed for different purposes, but the data items are the same. Blood pressure is still diastolic and systolic. The question is, do you need those extra pieces or not? So the traditional IT approach has been failing in healthcare because they've been redeveloping this data over and over and over. And I love what Dr. Chang said about the need for having it said once and used everywhere. I think that is so true. So I think about the standards environment. I think about OpenEHR is like the supermarket. It's got all the data on the shelves. And a particular implementation can pick the pieces of data that they want because it's already specified. So it's a maximal model that can be refined or restricted to local use. So you can make it smaller, but you can't make it bigger. That way you still have semantic interoperability. You need Snowman. It's a bit like the barcode and everything at the supermarket, so you can identify all the pieces. You have to have that. Without that, we don't get interoperability and we don't share meaning accurately. We need tools to use OpenEHR. Things like Meter is one of the software products that's used a lot. EHR Base is another open source application that use the standard items in your supermarket to create food by identifying recipes. Those recipes produce a screen design or a report or something else that allows you to pick off the shelves the standard things you want, put them into a package and create software code out of it. That then can get put into your software system. We then have HL7. It's the Uber Eats or the delivery system that knows how to collect the data, package it properly and appropriately, deliver it, and when you receive a delivery like that, your computer system can know how to unpack that message and put it on the right shelf in your refrigerator or in your cupboard so that everybody in the house knows where it's been put. That's a really important component. So I'm not saying we don't need HL7, because I believe we do. We need IHE, integrating the healthcare enterprise, who produce protocols. They are effectively the food quality assurance part of the delivery system. So they make sure that the food that's delivered actually is what it's supposed to be and is unpackable when it's received. Then we have ISO. Now, ISO produce standards on safety, governance, quality, and best practice. They produce standards, for example, on if you're going to map your data, how do you assess that this map is safe to use? That's an ISO standard that should be being used all around the world. Make sure our systems are safe. So that's how I see the standards world. But what are the barriers? The barriers are that we often have the people making decisions don't necessarily take charge of those decisions or have the new skill mix that we need to make this system work. And that's at all levels of healthcare, absolutely every level. We have our software vendors who don't want us to change. They don't want us to change because if we change to a standard model, then I can change my software provider really easily instead of it being excruciatingly painful and expensive. So the software vendors are telling our decision makers that in the countries I'm familiar with, I've seen it told by software vendors that this cannot be done. You cannot standardize the data. It will ruin healthcare. That is absolutely rubbish, because countries like the UK, Norway, Germany, Brazil, Jamaica, even parts of China, parts of Russia, parts of Slovenia, international requirement, are all adopting this approach because they can see it will be cheaper and safer. So if they can do it, what's stopping us? Well, we're being stopped because, as just about everybody's already said, you can't just do it in one hit. It's not possible. You've got to choose your pieces as you go. I know a couple of countries that are choosing obstetrics because it's already highly atomic data and it's a fairly easy area. I know some that have chosen, Brazil did some work in outpatient orthopedics as their first step. So they just did pieces. But the idea then is that we also have to allow the workforce to evolve. And that's a big problem too, because university programs take us too long. We will not have those people in positions of decision making, nor really being able to influence what's happening for, if we're lucky, 5 to 10 years. So we need to be able to teach detailed specialisms in a controlled and managed environment where the competencies are known, so that we stop. I'm really sick of going to environments where people claim to be really highly skilled in something, and they open their mouth and say something, and the minute they say it, I know they're not skilled. They might think they are. They might have used the system, but it doesn't mean they understand it. You know, I've seen SNOMED implemented around the world. I say SNOMED is feral, which means it's like a wild animal, because people don't know how to use it properly, and yet they're implementing it everywhere. National release centres have been taught how to use it, but they're not the people who are putting it into systems. And there's a big disconnect there. Countries like Jamaica set up a specialist education program over 12 months that included university professionals, government, healthcare staff, and their vendors, teaching them all about the different specialisations and skills that they needed. They had a call once a week, just for an hour. Didn't solve everything, but at least it got everybody on the same page. And that was really valuable. We also need recognition. I'm working with education providers to develop workforce capacity statements that say these are the skills a person should have if they're going to be safely doing X. And we're working on the publication of proper digital badging for those competencies. And that's a really useful process. So I guess to me, the opportunities and the benefits that I was asked to think about is if we get all of these steps working together, instead of just picking the pieces like SNOMED and Natural 7, we need them working together as part of this delivery. We call it the data supply chain in healthcare. We can get easier and cheaper implementation, stopping each individual hospital that implements things, using their clinicians to decide how I'm going to represent blood pressure. It should just be done once, and you pick from the selection we have. We want to be able to maintain and create our messages more efficiently. If the data begins in a standardised form, HL7 becomes even more powerful and cheaper to implement and cheaper to use. It reduces the expense for everything. One of the things it will instantly reduce is the need for dangerous data maps. Mapping from data in one system, where they collect it locally one way and then they map it to something else. And the people who are doing those maps don't have map skills. They think they know what they're doing, but I can tell you I've seen enough maps around the world to tell you they don't. The number of quality maps out there in healthcare that are safe are very few. I would be surprised if it reaches 5%, I'm surprised. We need to have receiving systems that can process the data they receive. That's part of interoperability. It's not just getting it there, it's what happens when it arrives. And to do that, we have to stop thinking about data as forms, we have to think about it as data. We have to have, one of the biggest things that I find interesting is that the software industry doesn't seem to have recognized the enormous opportunity that this approach offers. plug-and-play systems, so that each specialisation in healthcare could have high-end plug-and-play software available that is sold all around the world and used everywhere. If we were not hampered by the restrictions of the big software vendors who say, no, we don't want to interface with those sorts of things. It's time that healthcare took control of its data and its systems. Now, it's going to take a long time, I know, but we need to do it. If we want plug and play, if we want our professional bodies deciding on the best care pathways and the clinical decision support systems that are delivered in our software, if we want those professional bodies controlling it, and not each individual hospital deciding on its own, we can get higher quality healthcare and better quality data at a lower price. It also supports your objective that I've loved hearing you say so often about reducing the silos. You know, it certainly supports that option. So let's go for better quality data, less time to develop and maintain it, plug-and-play software, improve data analytics through reduced silos and better comparable data, improve data definition and governance by sharing it, using a tool like Orchestrator, Clinical Knowledge Manager, and having quality education that's based upon known certified competencies. I think I've been on my high horse here, sorry.
Thank you. Thank you, Heather. That was very useful. So, in fact, I'm happy how one speaker is actually giving a lead to the next. And this is where the barriers and workforce evolution comes into picture. And we have Dr. Vasant Kumar here, who at the UPTSU is actually helping Uttar Pradesh government tide over this problem of digitization, and they've played a key role in bringing UP health facilities onto the ABDM platform. So, so on-ground experience and as to how and what kind of capacity building you think is required at the ground level to be able to achieve systems that are interoperable and take them forward. We'd like to hear your thoughts on it, Dr. Vasant.
Thanks, Kiran. Good afternoon to all. So I come from a public health background, and as Kiran told, I head the technical support unit for the most populous state in India, the population around 240 million. So I'll kind of base my points on 4 buckets. You know, how do you make integration and interoperability for non-electronic health record generating systems, for electronic health record generating systems, and then use today's 2 example of the commodity exchange CX and the UHI. Like, what constraints do state face in basically adopting these, and what possible instruments are there to overcome these challenges? First of all, with reference to non-electronic health record generating systems, the first is to adopt the registries that are being created under the Ayushman Bharat Digital Mission. Most state governments, because of the push from NHM, has HR system, has DVDMS, drug supply chain system, has family planning supply chain system, has many other systems. But as Kiran was telling, in UP's case, we had a UP model where we have a digital system of all our health facilities, geo-coded. It's a live system. Whenever new facilities gets created or gets upgraded, it gets onto our system, and it is API integrated with the NHA, and we thank NHA for that. And we have generated the HFR for all our public health facilities. Now we have also integrated the same HFR ID in our human resource management system, in our financial management system, in our other systems, and we have also, so that we can see at one place, at a facility level or at a geography level, how different aspects are coming. These are all non-electronic health record generating systems. One constraint that we face, though I think, and NIC will not agree, is still actually API integration. We have put open API for our HFR now, but it is very difficult to make API integration and get in and out from NIC, so we need to really work on that still at the state level. Coming to the electronic health record generating systems, I assume that ABDM, NHA is going to put all the standards, and the sandbox and all the standards will be out for all the stakeholders to take use of it. But sandbox integration has two issues with reference to legacy systems and the new systems. We have many legacy systems like what sir was telling, Nikshay or even eSanjeevani and other things, which has to go through the process of sandbox integration. National systems are pretty easy because they have the financial backing, but many state systems in the value chain of care, which are legacy, do not adhere to the standards. So how do we make sure that they go through the process of M1, M2, M3, M4? Particularly, most of the developers have been small companies which do not have capacity to go through this sandbox integration process. So we need some help both in terms of cost as well as capacity building of the developers. For future applications, probably either we need to make an RFP condition that these companies should show earlier capacity to integrate with the sandbox, or make it that every new application should be integrated with the sandbox. What are the constraints that we feel at this state level? One possible thing is, this entire conceptualization. These are complex things which we spoke, right from SNOMED, HL7, all the other standards, and ABDM is integrating all the standards of standards. So it's a very difficult conceptualization piece, particularly when the senior management at the civil servants and at the directorate, more so at the directorate, keeps on changing at very frequent intervals. There's a huge change at the state directorates, and as well as in the bureaucracy, that how do you keep this conceptualization piece going on with change management? That's one difficult piece that we really face. Probably you have at the national level a lot of volunteers who are really great thinkers who are helping NHA. How do you create an ecosystem at the state level for volunteers? TSU can probably do that role a bit in terms of doing this change management with change in leadership level, but it's still TSU's is kind of, it may be there, it may not be there kind of situation. The second part is, what was told in terms of weight of data. Whenever I sit in a meeting with this, e-hospital implementation, I'm so worried of the number of data points that they want to capture. So I always tell, never make a doctor and a data coder sit together. I myself a doctor, so it becomes very difficult because they ask everything under the sun and then it collapses with the weight of the data that we want to capture. So how do you make sure that we capture the essentials and don't capture, whether you want to capture my BP is this and this, or you want to capture my diagnosis as hypertension. We need to be really clear on what we want to capture and what we don't want to capture. So again, TSU can play a role in de-risking and kind of giving pilots and other things for a short period of time. Maybe that instruments can be used. As a public health person, we are always worried about time, place, and person. Your ABA ID gives me the person, electronic health record gives me the time, but it doesn't give me the place. So what we think in UP, again as a UP model is, can we generate ABA ID using ASHA? ASHA frontline workers, beautifully they have village health registers, they have 1,000 people under them. If I generate in an organic way, where there's a first point of contact with the health system is my ASHA, and she actually enumerates every time and gives me denominator. As a public health person, one thing that is always absent in any of the meetings is denominators. It gives me the denominator in this 1,000 people who are the 50 plus who needs cataract screening, who are the 30 plus who needs health and wellness centers screening, who are the eligible couples. Every denominator comes from me as a one-time enumeration followed by just updating 25 births and 7 deaths that happen annually. So it also gives me one other advantage, which is family. Family ID can get generated through the same process, and it can be universal and multi-generational to really do planning. If I want to know end-stage renal disease load over 25 years period, I need to see a 25 years before history of how many families had diabetes. So it gives me that advantage. So, but the only issue is we need to kind of allow ABA ID generation in an offline mode using demographic authentication as one of the methods and not as a rare method. So if that's the case, we will be able to actually onboard millions of people in Uttar Pradesh using 1,80,000 ASHAs are there covering 17 crore population in the rural areas alone. So the other thing that we really want to bring in for the state capacity is in a federated architecture, as sir was telling, some women may have diabetes also and pregnancy also and tuberculosis also, residing in different data systems. We want to engage with institutions like IIT Kanpur, which can provide anonymization as a service, basically not revealing the identity of the individual, but at the same time allowing me to send a command, get the data, say for example from January 1st to June 30th, who are the women who are having diabetes, pregnancy and tuberculosis. So I don't identify the individual, but I have ability to get back the data and really use it for public health purpose. So it's, say for example, if we find a dog bite going to 10 different hospitals in 10 different data systems, if I have the ABA ID generated, as I told, from the ASHA, I can probably find out they are all coming from the same village, or even a SAM child or a MAM child. So we need to really now bring in the institutions, which are particularly academic institutions with high capacity, in an organic linkage with state government. So we are trying that, but we need NHS help to really identify top institutions for each state, because I work for a Canadian university on deputation now. 20 years they have been able to work with governments that, whereas Indian academic institutions find it difficult to work with governments particularly. How do we develop the capacities within our academic institutions to work with governments also is another thing that we need to find. Digital health capacity building, both as a consumer of data and a producer of data at every level, right from ASHA, CMOs at the top level, is a big issue that we are going to face, and we again feel that institutions are required to do the digital health capacity building at various levels for the state government. Adoption, as COVID was adoption, UP has a COVID portal which was adopted during COVID across the testing, tracking and treatment part. Adoption particularly of electronic health record in OPD, in the way that public hospitals function, is going to be a big challenge. So how do we ensure adoption happens again at the government government facilities with high OPD load? And we would also request NHA to give what does a consumer facing application should look like? Should it be multiple, or what standards should be there? What are the components of a consumer facing? Is it only appointment fixing? Is it feedback mechanism? Is it IEC, BCC? What are the different sub-components that are required within a consumer facing application? So on the electronic health record, these are the different constraints, these are the issues that the states are facing, and hopefully we will find a solution by a combination of volunteers, technical support unit and institutions which can solve it. Regarding health commodity exchange, Kiran, I think we know that the cost of premium is high because there's a huge pre-processing that goes into different insurer adopting different systems, and also for PMJOY, many of the private people do not get onboarded because of the delay in actually the processing of the payment. So obviously here it's going to be lesser cost of premium as well as better onboarding of private hospitals onto PMJOY. I think here we can use the regulatory instrument easily. IRDA could be one way because obviously it's a. But what I visualize is the secondary benefits. This administrative data of diagnosis, diagnostics, and the disease that comes, disease coding that comes, can be used again, as I told you, with administrative data of electronic health record for public health purpose. It's going to be very useful when we adopt the HCX part, but I think regulatory instrument could be the one. The final, I think the difficult one is UHI. As he was telling, internet is a protocol, our mobile phones are a protocol, our emails are a protocol. How do we convert platforms to protocol? Particularly in a situation when all the companies are having customer base and stickiness as one of the issues. So that's going to be a tough piece. Maybe if adoption goes, we kind of use a micro-geography kind of model where we take and demand side work is done, particularly 40% adoption is done, and then the citizens start asking for it. Probably we can drive the UHI adoption more from the demand side aspect, because I'm not able to find an easier supply side aspect which we can do. I'll stop there, and thank you very much for the opportunity.
Thank you, Dr. Vassal. In fact, sometimes, while you were speaking, it felt like, oh, I should now stand up and answer what we are doing. When you say what kind of an app should be and what kind of features it should have, I felt like saying, oh, we are having the reference applications. But it also tells us that we need to have this dialogue with the states and tell them and inform them about what we are doing, and that conversation is more important. We have heard all the speakers now, and I think with the permission of the chair, we can have some questions from the audience also, because they would also be quite eager to ask a few questions and get some clarifications. Kindly be concise. We have overshot our time a bit. We have started a little late also, so we think we can do that. Kindly be concise and ask questions, and you may in fact direct your question to the concerned speaker also. That will be useful. You may just raise your hand and somebody will come and give you the mic. Yeah. यहाँ दे दीजिए. Here.
In the meanwhile, what
Sir.
I'll just respond to the Vasant is that in the recent mission steering group of the NHM, it has been now decided that for creation of every ABHA ID, ASHA will get a 10 rupees incentive. So we hope that the creation of ABHA ID will further increase and it will take a very speedier rate.
Yeah, fantastic discussion. My question to Mr. Vishal, sir, what is the plan to make this ABDM ID mandatory? Because what we have seen, the policy decision actually make other thing works. And as you rightly pointed out that what things has worked when you were in the power sector and how that exchange has helped to reduce things. Probably one particular decision can make a lot of things work much faster. So is there any work going on in that direction?
Making mandatory, I would not, probably NHA is the best position to answer this question. But from my side, my personal view is that, if the citizen find it useful, if the ecosystem, people in the ecosystem, it's a hospital or the lab or the healthcare providers find it useful, people will themselves use the ABID or the ABDM ecosystem, because this we have seen in case of Aadhaar also. If people found it useful on their own, people kept on making Aadhaar, and today we have more than 99% coverage. So similarly, ABHA ID also, I am sure that if people will find it useful, I don't think at a personal level there is a need for make it mandatory.
Yes. Yeah.
Just to share an idea with everybody, Kiran, if I may.
Yes.
So I think what we've heard is that the tools are there, the mechanisms for implementation are there, and so on. And why is it getting done? I think why it's not getting done is if if you don't set targets and if you don't measure and evaluate and hold people accountable, it doesn't get done. So I think that is probably one of the most important things that we need to focus on. And if that is done, it will get done.
Yeah. Please.
Would there be any attempt?
We can't hear you.
Hi, I'm Oman. I'm a digital health researcher. I would be interested in knowing, are there any attempts at standardized data dictionaries that could be a common good that hospitals who want to adopt for the standardized EHR, as it were? Is there any attempt at all from the NHA on that, or any of the partners working on that?
So, I think I'll take that question. So you are saying, are we creating any standardized data dictionaries that hospitals can use? See, the whole objective of ABDM is to create more a tech layer that enables and encourages people to create new goods that make the life of hospitals and other care providers easier. So the tech layer actually helps you to create any kind of information and share it, and anybody can use it. I mean, it could be an AI-enabled clinical decision system. It could be a speech-to-text kind of a system, anything like that. So NHA per se is not creating any such things, but we are actually encouraging anybody. In fact, we have also an EOI, which is an open EOI, where anybody who is creating any such kinds of public goods which they want to give away as an open source good, which others can use. So we encourage them, we help them standardize it, we give them a platform, and then make it open to everybody and tell everybody that, see, this is available. If you want to use it, you can use it. And if you find it useful and more people find it useful, it actually it develops further, and an ecosystem develops around it. That's the idea behind how we work it out. I thought we had a question from there. Yes.
Thank you so much. The different perspectives that we got from each and every panel member online and offline was really amazing. Thank you for that. My question is that small hospitals sometimes find it very difficult to have access to the right IT people and then to implement, and then sometimes it's just a 3-month, 6-month, 9-month or maximum a year's job. and then you don't just want to hire and fire people. So is there a system we are planning to develop where these people can have access, the knowledge, again, finders, you know, where do you find the people who can help you implement this digitization that we are talking about? Because I don't think everybody has access of where to go, who to go, and how they're going to help them, whether it's API integration with labs, whether it's digitization of records, and so on and so forth.
Thank you. I think from interoperability discussion, this actually transformed into an ABDM discussion in general, but it's a very important question. And we actually acknowledge the fact that it is difficult for small hospitals, small labs, and the smaller entities to find these kind of IT solutions. So we at NHA are taking a few steps like this. One is we are trying to identify softwares which are ABDM enabled and which have a minimum viable, what we are calling them a minimum viable product, that who have these features and are ABDM enabled, plus who are actually providing this software in the form of software as a service at a very minimal cost. In fact, we are on what we are also doing is we are listing them on our web page, and just like you can actually compare, let's say you want to buy AC, air conditioner, you go to online web page like Chroma or Reliance Digital, he gives you all these options and then you do a compare what features each one has. So we've done something like that. Plus, one of the things that was mentioned by CEO NHA during his presentation was repurposing CoWIN. Not only for it as a universal immunization platform, but also the vaccinator module of CoWIN is a very, very easy, simple, lightweight module that a lot of entities have used during the COVID period. Now that is being re-engineered, reprocessed into a small, lightweight HMIS. So if I am a single doctor clinic, if I have a single doctor clinic and I want to use this, it's as easy as you would create a Gmail account. So you simply create your account and then you create an account using your HPR ID, the professional ID, and from day one you are ready to now take patients and create their records, which would be digital, which you can then share with the person, because this software would anyway be ABDM enabled. You will be creating ABHA, you will be linking records, you will be sharing records, plus we are also trying to put the teleconsultation layer on top of it. So this way we are trying to address the concerns of the smaller players in order to make sure. Plus another thing that we also trying, and this is something we would like to push further, is building this franchisee kind of model. When Harley Davidson comes to India, it doesn't have a mechanic center everywhere. They actually give this franchisee to someone, train somebody, and then put them in different places. So that is a model that we are working on, so that people can actually start using them, the local vendors, so that they can help it out. So these are different ways in which we are trying, and all the softwares we are making are also making sure that they are interoperable, so that what records you create are useful by someone who is using a different kind of a system. That's the idea. Thanks.
Karen?
Yes.
Could I jump in on this one?
Yes, please. Yes, Chang.
Yeah. Actually, because the question, I think it's a very pertinent one, because it's actually not just small hospitals that have to do this. As Heather noted, it's actually very difficult. Even large hospitals, especially if they don't have the willingness to, invest in how to find the right people. And there aren't that many people who really understand this stuff. So I think it's a very pertinent question. One of the things that we did in Hong Kong, trying to get the interoperable system out from just the public healthcare sector into the private sector as well, was to build actual software that you could just throw into their existing systems, into their existing environment, or as you've done, some of it's web accessible. So the thing is, they may not, because we're not providing the full service that a commercial vendor might do, just providing software. So there's two things there. First of all, if somebody in Canada, they can use it. It's easy to use, but it doesn't come with some of the bells and whistles. Now the other thing it does do, though, is we're essentially building also a reference model. So it's sort of like, how Intel does that a lot. A lot of commercial tech companies build these reference models, not necessarily to sell a lot of that product, but to demonstrate So that's also what we're doing. So we invested enough to make these things, they are plug and playable. But if you like a more fancy thing, we hope that we demonstrate to the vendors, this is also how you can do it, to make it a fully interoperable system. And to some degree, shame them into saying, look, it's not that hard. As Heather said, they'll say you can't do it, but it's really not that hard. So then, shame them into actually doing it. So we've sort of done that as a strategic policy sort of level initiative.
Yeah, in fact, I'm happy you mentioned that because making reference applications is also one of the things that we are doing. So the unified health interface has reference applications for the user, that is the patient, and also for the provider, that is the hospital. So those reference applications are there which demonstrate the capabilities of what the unified health interface can do in terms of allowing interoperable calls, allowing discoverability, allowing bookings in an interoperable manner where the data can flow from different systems. So and thank you that you brought that point out. Yes, I think at the back end you already have a mic. Yeah, we'll come back to you, sir.
Yeah, I'm Dr. Girish from NIMHANS, Bangalore. Quite interesting discussion. A question to Dr. Venkatesh. We have been talking about the consultant from UP.
Yeah, he's Dr. Vasant.
Sorry. We have been talking about interoperability between technologies. Just wanted to get your thoughts, insights, and experience about interoperability between humans and the technology. Any magic formula you have, or what could be the way forward?
Okay. These are just off-the-cuff thoughts. One part is that if you buy a remote or ATM, if you go, no one is teaching people how to switch on a TV or how to change channels or anything, and they are in such a intuitive way that you learn the digital product and it is useful to you, you adopt it. So one way is to really put a lot of effort in designing the system in a user-friendly way. Human-centered design is talked about a lot, but I think, at least in my experience, most of the applications that I've tried are not very friendly to the users that are there. One is that how do you make sure that it is useful to the people, it is friendly to the people. If systems can be designed for really not so digitally literate people, it will be much easier for everyone to adopt. The second part is that one criticism that is always told by the doctors is that when you put a system in front of me, the patient satisfaction level goes down because I'm always working on the system and I'm not actually talking to the patient. But I think this has crossed in many countries this stage, and it's not an either-or situation. There are ways to really make sure that the patient satisfaction level while the care provider adopts digital system is not gone down. So that's I think it's a way that we have to cross that path, but initially there's going to be a lot of criticisms, both I think more as an excuse from the doctors to tell that patients are not very satisfied if I start looking at the computers and not there. The third myth which I find is that the last mile health worker will find very difficult to use technology, whereas the top layer will be finding it easier to use. That's exactly the inverse as far as my experience is concerned. It's actually that in the hierarchy, the lower level people, if designed well, adopt technology far better than actually at the top layer. So I think these are my initial thoughts. I don't know whether I've answered your questions, but I would say the interaction is going to be pleasant if it is designed well and we take into consideration the end user.
Thank you. Yes.
Thanks for a very excellent
This will be the last question for the day. Sorry.
I am coming from the field and a lot of clarity on the integration and interoperability with the existing app taking to the next level. My only question is at this moment is that this Arogya Setu is repurposed. Is through this Arogya Setu automatically our number will be generated, or if you have registered on Arogya Setu, then you have to go independently to register for our number? Thank you.
I think again I'll take that question. In fact, our Arogya Setu is already ABDM enabled. So you can create your ABHA number using Arogya Setu directly. You don't have to create it separately. So you use your Aadhaar and you can straight away do it if you have an OTP on that. So that's how simple it is. So because this is, I mean, that's how we are saying that we are repurposing it. More and more features would be added on top of it.
Okay, thank you.
Thanks.
So last question, here.
Okay, because this was a short one and I'll allow you the last question. Yes, please.
So I come from a health tech company and I've been working with many private hospitals in digitizing their medical record. And I see that the ABDM initiative is quite a lot in transforming everything in health sector. But I knew the phase one is all about bringing the public health services. And that does pose a challenge for us because many of the private players also need to be brought on board in terms of adopting the new ways of working. So is there any roadmap we have in place to make it inclusive to all the parties? Jesse.
Again, sir, with your permission. In today's presentation, the CEO mentioned that there are more than 1,000 partners integrating with us. Hardly 40 of them would be government. Government is more in terms of numbers because the programs and also the state government run institutions, we touch more people. But otherwise, in terms of people integrating or joining ABDM, it is more private players than this. If you look at the expo, there are only 4 stalls for government out of 40. Rest all is private. And I'm happy you asked about the roadmap. In fact, that is one of the things we completely agree that we also need to have a roadmap as to what kind of enablers in terms of policy, incentives, etc., that need to be used to push this adoption and make sure that more and more people come quicker. See, the way we have shown it, it took us more than 300 days to reach 1 lakh. And then you know the story. Now, we really want to move it even faster. That is why the roadmap was unveiled today. The roadmap specifically talks about how each of the ecosystem player, where the private players are a very, very integral part, will be brought onto the platform through various means and how we can help them. Right from technology support, integration support, and also trying to find the right investment partners for you. So that is all is on pipelines. So I think with that, sir, we can end the question, sir. We have some prizes to be given away because basically we had a hackathon for UHI and we had a lot, 70 entries in that, more than 300 teams participated and we had 70 entries, of which some were very, very good solutions and they actually made real interoperable solutions. We thought this would be a right forum to give them some of their awards, sir, with your permission. And I also would like to request CEO sir to kindly join us in giving away these prizes. If you don't mind. And we also have state governments.
Thank you so much, sir. The Kickstarting UHI Hackathon was conducted on 14th July and was aimed to promote interoperability and innovation in digital health. As a part of this hackathon, we have 20 winners. The award for executing an end-to-end physical OPD appointment as well as an end-to-end ambulance booking goes to the coding company. Team, I please request you to come on stage and collect your reward. Congratulations to the team. Shri Vishal Chauhan, sir, we request you to please provide the award. This is for coding company. This is the first award for coding company.
The prize money they have won.
Coding company has received 2 awards, the award for executing an end-to-end physical appointment, which was challenge 1, as well as the award for executing an end-to-end ambulance booking, which was challenge 3. Congratulations to the team for winning 2 challenges. Next, we have the challenge for enabling intelligent search, and the award for this goes to Oracle Cerner and Team Stanza. Request CEO sir and Vishal sir to present the awards. Thank you. Yeah, 1 second. Challenge 1, Innovation 1 for Oracle Cerner. The challenge for enabling intelligent search on UHI. Congratulations to the team. The second place for Challenge 1, for Innovation Challenge 1, goes to Team Stanza. Request the team to come on stage. Team Stanza. Congratulations to Team Stanza for winning the second place in Innovation Challenge number 1.
You keep it in the front. You come here. One of you can come here.
Award for enabling interoperable group consultation goes to Health Talk. Health Talk has received the second place in this challenge. I request the team to please come and collect their award. This is challenge number 2, enabling interoperable group consultation. For challenge number 3, which was to optimize record viewing and easing entry of symptoms. The first position goes to Bajaj FinServ. Congratulations, team. This is the award for challenge 3 for optimizing record viewing and easing entry of symptoms. The first place goes to Bajaj FinServ. The second place for challenge number 3 is Protein. Request Team Protein to come and collect their awards. Congratulations to the team. The winners for challenge 4 to develop triaging and clinical support system. The first place goes to Right Ratio Technologies. This is challenge number 4. Right Ratio Technologies, challenge number 4. Request you to come to stage and please collect your awards. And the second place, congratulations to the team. For winning the first place in challenge number 4. The second place goes to Team Oracle Cerner. Request you to please come on stage and collect your awards. Congratulations to Team 4 Oracle Cerner for winning challenge number 4, winning the second place in challenge number 4, developing a triaging and clinical support system. Congratulations to the team. Challenge 5 included optimizing prescription and diagnostic generation through handwritten script. The award for this goes to Team Stanza Team Stanza, request you please come on stage and collect your rewards. Team Stanza. Team Stanza has come the first place for challenge number 5. Congratulations to Team Stanza. The second place goes to plus 91 Technologies. Plus 91 Technologies team, I request you to please come on stage and collect your award. Okay. For challenge number 7, the award for introducing features and application to ease processes for healthcare administration goes to Health Talk team. Health Talk won the first place in this challenge number 7. Request the team to come and collect their award. Congratulations to the team. The second place goes to Karkinos Healthcare. Karkinos team, request you please come on stage to collect your award. Congratulations to the team. The last challenge included developing any innovative feature that can enhance adoption for ABDM. The prize for this award goes to Larry Page. Larry Page, team Larry Page, request you please come and collect your award. This is Innovation Challenge number 8. The first position goes to team Larry Page. And the second place goes to Team Health Talk. Health Talk, request you please come on stage and collect your awards. Yeah, the plus 91 team is here. The plus 91 team is here as well. We'd also like to use this opportunity to award the top performing government facility based on number of health records linked to ABHA in a 50-day period. For this, the award goes to KC General Hospital, Bengaluru and District Hospital, Vijaypura, Karnataka. I request Sri Randeep, Commissioner, Health and Family Welfare Services, Government of Karnataka, to please come on stage and receive the awards. The two hospitals have linked 4,000 records each in a 50-day period. That's it.
Just wanted to add that this in fact answers that human-machine interoperability question that you posed. All the solutions who have won the prize here actually aimed at finding solutions that ease record creation. So something is a speech to text, something is a clinical decision system, something actually helps you diagnose better. So all these solutions, these teams have actually prepared over a period of a 4-day hackathon, and they have already all given it to us as public goods. These are now available open source solutions which anybody can use. So that is the beauty of the collaboration that we had. Thank you. The last thing, sir, I may request CEO sir to kindly give away mementos to the panel members as a token of our gratitude. Sir. Thank you. With that, we would like to, the virtual participants, we will send you virtual mementos. we tried to bring you here, but unfortunately because of your time commitments, you could not join us. I would like to thank on behalf of NHA, the chair, Vishal Chauhan sir, and all the speakers who have traveled afar to come and join with us, and also those who have been able to join us online and share their views on this very important topic. And this discussion will actually help us frame our roadmap and also enhance our roadmap and improve our systems and processes as we go ahead. Thank you all once again, and all are invited for lunch after this. Thank you so much.
Thank you. Thank you.
Thank you so much, everyone. The lunch for all of you has been arranged on the second floor in the Ruby and Emerald halls. That would be near the main lobby. Please proceed to that area. Thank you so much. The Ruby and Emerald halls on second floor near the main entrance.